Okay, so today I wanted to review, there's been a few new trials that came out early 2015, stroke trials that have changed the current management of ischemic stroke. And I wanted to touch on a little bit on the results of those trials, what they used to kind of triage the patients, and then finished with what we can use here to do the same. These are the objectives for this talk. So ischemic stroke, you know, is when an artery in the brain gets blocked, either by a thrombotic or embolic occlusion, and it's far more common than hemorrhagic stroke. When that clot breaks up spontaneously within 30 minutes, then the brain cells, the neurons don't die, and the patient's symptoms resolve, and that's what we call a TIA, which are symptoms that resolve within 24 hours. Ischemic stroke has a 20% mortality and a 40% moderate to severe deficits, which would contrast with hemorrhagic stroke, in which these numbers would be flipped. Hemorrhagic stroke has a 40% mortality and about a 30% morbidity with severe or moderate deficits. Stroke is going to be the leading cause of disability and the fourth leading cause of death in the US. Of all the strokes we're going to get in the ER, 80 to 90% are going to be ischemic, and approximately 800,000 people will have a stroke this year in the US. So you can see with those numbers, you can see why a lot of resources have been put into trying to develop something that works for these patients, that we can help them be independent or at least don't have a big deficit. So 800,000 persons will have a stroke this year. Major risks, we know them: atherosclerosis, high cholesterol, hypertension, diabetes, smoking. So we're in the belt stroke here. Any patient that you see that has a acute neurological deficit or an alteration in the level of consciousness, think stroke. Our initial goals when the patient gets to the ER is going to be confirm that the patient has a stroke, and we can do that with a CT and a CTA. The CT will tell us if the stroke is ischemic or hemorrhagic, and the CTA will help us determine if we have an ischemic stroke, if it's because of a major breast-cell occlusion, a dissection, or maybe it's a lacunar stroke and we're not going to see any branch occlusion in the CTA. And if it's a hemorrhagic stroke, well, the CTA will tell us if it's an AVM, an aneurysm, etc. We're going to establish a baseline for the patient and a severity, and for that we use the NIH stroke scale, and we're going to determine the time of onset if we can. A lot of times the patients come in the morning, they say they woke up like that, so we don't know the time. And that's when the advanced imaging comes in play. What are the treatment options for these patients that have a stroke? Well, since 1996 we have IV TPA or alteplase, and it was approved for a window of 0 to 3 hours of onset of symptoms. In 2006 it was extended. There was a European study that showed that some patients were given IV TPA up to 4.5 hours, and that their results were also good. So on the American Heart Association released an advisory that said that it could be extended up to 4.5 hours if there was nothing else that we could do for the patients. The FDA had no position on that, and then recently the FDA approved the TPA up to 4.5 hours, but they had a few additional exclusions, including age and INR, more tight INR results, and a lot of other exclusions. Diabetes is one of the exclusions. So the patients that qualify for that 3 to 4.5 hour window are really, really small. Then an NINDS trial with IV TPA showed that patients that had an NIH score of more than 20, which was a severe deficit, only 8% of them had favorable outcomes. So because of all this, the neurointerventional stroke rescue grew very rapidly. The industry was trying to come up with devices that could help these patients take those, either dissolve the clot with intraarterial TPA or remove the clot with mechanical devices for fast revascularization. But throughout the years, we had always failed to have a trial, or we had a lot of case series and registries that showed that endovascular treatment patients did better than just patients that had IV TPA, but there was never a randomized trial that showed that. So we kept looking, we kept treating those patients empirically, because we saw just that patients that went to endovascular treatment had better results than the one that just got IV TPA. You can see here what we had. We had retrospective reviews and registries, and but no randomized trials. And then in 2013, many of you may have heard of IMS3. This was a trial that was done randomizing patients to the endovascular, an endovascular arm and an IV TPA arm. This was, they started recruiting patients, I think around 2008 or something like that. I don't remember the name. And then they had the results in 2013. And their results were that endovascular treatment did no better than IV TPA. So after this, there was a lot of discussion. There was, I mean, this paper was criticized widely because, number one, they didn't use any advanced imaging. They didn't use a CTA to corroborate the patients had actually a stroke or had a major branch occlusion. So this was all done symptomatically. And the reason was the CTA was not widely available when they started recruiting patients. And then the other thing was that the devices that they used were outdated. They were not devices that we were using in 2010, 2012, which were these mechanical thrombectomy devices. Their devices was the MRCLEAN device, which was the first mechanical thrombectomy device that required several passes, and it actually didn't work very well. What happened with that device is like a corkscrew that you put in the clot and then try to take the clot out. And a lot of times that clot got disrupted, it broke up and to pieces and then just embolized everywhere, and it would require several passes to take it out. So this trial, I mean, it had a lot of patients, 434 on the endovascular arm, 222 in the TPA arm, but it took them so many years, and they didn't have advanced imaging, that the results were pretty similar. An MRS less than 2, 40% in the endovascular arm, 40%, 38% in the TPA. You have the MRS score here. An MRS score, modified Rankin scale, less than 2 means that the patient is independent, has independent living. 3 or more patient requires some kind of assistance. So all these trials will use that modified Rankin scale less than 2 as their primary endpoint. Well, after this, a lot of things changed. Many people just stopped referring for endovascular treatment. Insurance companies stopped paying for endovascular treatment, et cetera, et cetera. So, of course, the people that did this and that saw the patients and saw the results were not did not believe the results of this, were not convinced by this. But even if we look at the Rankin analysis shift, we can see there was a little bit of better outcomes in the endovascular arm, but this was not significant, and that's why that paper didn't do well. So what were the takeaways about that IMS-3 that came out in 2013? Well, that the use of the newer stent thrombectomy devices may improve the long-term neurological outcomes, and that there was a need for future randomized studies using these kind of devices that were almost not used in the IMS-3. And that enrollment has to be done confirming large vessel occlusions, and not just with the patient having or thinking that it has a stroke. Because what happens is actually patients that do not have a large vessel occlusion, those are the ones that do better with IV TPA. So those little branches that get occluded, just the IV TPA dissolves that clot pretty easily. But the major branch occlusion, which is from the M2 down, M2, M1, ICA terminus, A1, ICA, those patients, the IV TPA does nothing for them. So December, then we fast forward December of 2014, and we have this MRCLEAN study. This was done in the Netherlands. It was a prospective multi-center randomized trial that randomized patients to usual stroke treatment versus usual stroke treatment plus endovascular. The treatment window was 6 hours. So the control arm got medical management, usual stroke treatment for that patient that came in within 6 hours. If it was within 4.5 hours, they got IV TPA. If it was after that, they didn't. And the study arm was endovascular treatment with either TPA intraarterially or mechanical thrombectomy. All the patients had a CTA done, and they had a confirmed distal ICA, M1, M2, A1, A2 occlusion by CTA. We can see here there were 233 patients in the study group, 267 in the control room. The characteristics were very homogeneous. The mean age, 65, males. Everything was very homogeneous. NIH score at presentation, 17 for the intervention, 18 for the control. The pre-stroke MRS also very homogeneous. So all the patients were, both arms were very homogeneous. And these were the results that they found. You can see the blue arm is the study arm, and if we see that from 0 to 2, there was a difference of outcomes. And when we get to 5 and 6, there was no difference. 6 would be death, 5 is severely disabled. So what was the difference with IMS-3? Well, 97% of the patients received mechanical thrombectomy with the stent retrievers. Only a minimal portion received intraarterial TPA, and another minimal portion other mechanical devices like aspiration. So 97% received stent retrievers. The Rankin shift analysis, we can see an MRS of 2 here, from here to here, from 40% in the control, from 20% in the control room to almost 40% in the intervention arm. So everybody was very excited. This was published in the New England Journal of Medicine in January 2015, because finally there was proof that the endovascular treatment of stroke was better for the patients than just medical management. So at the same time, there were 5 other studies going on, and all of those studies were halted in December of last year when the results of Mr. Clean came out. And all of these, except the last one, use the Solitaire device. Solitaire is a stent retriever. All of them use that, except that last one, so we're not going to touch on that last one, that use a different system that is an aspiration system. Time window, 6 hours for most of them. Some of them went up to 8 hours, some of them went up to 12 hours, and of course this, all these studies had advanced imaging to support the treatment. So Swift Prime is the Solitaire with the intention of thrombectomy as primary endovascular treatment. The study objective was just to determine if the subjects that had acute ischemic stroke with large vessel occlusion treated with IVTPA and the Solitaire device within 6 hours have less disability than the patients treated with IVTPA. Target vessel, again M1, carotid terminus ICA, so all these patients had a proven major branch occlusion. There were 90 centers that were enrolling, 50 in the US, 40 outside the US, and the target was about 800 patients, expected to have about 500 patients, but this was halted with 300 patients in December of last year. These are the features, the characteristics of the study arm and the control arm. 150 patients in the study arm, 148 in the IVTPA arm. Also very homogeneous patients. The time to onset to IVTPA, 110 minutes for the study arm, 117 for the control arm. So they all got IVTPA about the same time, except these patients, when after having IVTPA, just went to have the endovascular treatment. So this is the shift analysis. You can see in this was a very striking difference between the patients that just got IVTPA to the patients that got endovascular treatment plus IVTPA. So more than twice of the patients in the study arm did far better than the ones in the control room. The technical success for the stent retriever was 88% of the patients had reperfusion TC2V3, and this is an analog of the TIMI recanalization scale for coronary arteries. So this is for cerebral recanalization, where TC2V would be recanalization of more than half of the territory that was previously occluded, and TC3 would be a complete recanalization, 100% recanalization. So more than half, or 100%, was achieved in 88% of the patients with that. That study is under review to be published also in the New England Journal of Medicine. Then after that study, the Extend-IA also was halted. The results for extending the time for thrombolysis in neurological deficit intraarterially, as opposed to the previous one, which was industry funded, this was investigator initiated, multi-center, prospective, randomized, blinded for IVTPA within 4.5 hours of onset, and IV TPA plus endovascular treatment. This is just the difference between the two arms. In blue, we have the study arm. In just brown or yellow or almond, you have the control arm. Reperfusion at 24 hours was assessed with a CTA. 100% of patients within the stent retriever arm were reperfused, compared with only 40% in the control arm. And these were all patients, again, that had a proven occlusion of a major branch. MRS less than 2 at 90 days, 70% of the patients in endovascular against 40% in the patients with only IV TPA. And the mortality, in this case, actually patients that went endovascularly had less mortality than the patients that went to IV TPA. And intracranial hemorrhage, symptomatic intracranial hemorrhage, 0% for thrombectomy, 6% for IV TPA. In this study, they used CT perfusion imaging as evidence for salvageable tissue, and they used an ischemic score of less than 70 cc's to accept the patient into the endovascular arm. This is the Rankin shift analysis. We can see that there's also a big difference. This would be 1, 2, big difference, 25% there for TPA alone, and 45% for TPA plus endovascular for Rankin scale 2 or less. SCAPE trial, endovascular treatment, small core and proximal occlusion. Patients were included up to 12 hours of symptoms, but they had a CT, CTA angiography, CT perfusion. They assessed patients on core size, collaterals, and they documented anterior circulation and proximal intracranial occlusions. They assessed 316 patients and also came up with the same results. This is also in the New England Journal of Medicine. I think these last two are in the February issue. Again, very homogeneous population. ICA terminus, almost the same, 39 against 45 in the intervention group. M1, M2 occlusions, 105, 110, 111, M2 occlusions, 3 and 6. So the site of vessel occlusion was very similar in both arms. And they also, in the shift analysis, found a striking improvement in the outcome of patients that receive stent thrombectomy. And this is one of their conclusions, that patients with acute ischemic stroke with proximal vessel occlusion and small infracord and good collaterals, rapid endovascular treatment with the solitaire resulted in significant clinical benefit and reduced mortality. You can see 6 is death, 20% in the control arm, 10% in the intervention arm. So what are the stent retrievers or stent retrievers? They're mechanical thrombectomy devices. They have an overlapping stent design, and they're attached to a pusher wire, and they cannot be implanted. So it's like a stent. It's just a stent, but it's attached to that pusher wire, and it cannot be left behind. This is the design of the stent. This is the solitaire. This is the pusher wire. This is the attachment zone. There's a proximal marker, and there's 3 distal markers. The stent is not radiopaque, so we see the distal markers and the proximal marker, and that's the length of our stent. They were approved in 2012 by FDA, but they received CE marking, which is a European marking, since 2007, December 2007. So they've been used in Europe since 2008. They can be used up to 6 hours, or after that, you can use them 8 hours, 10 hours, but with advanced imaging showing a small infracord. Time is relative, and we're trying to move towards physiologic selection of the patients. All the registries and retrospective reviews showed about a 75 to 90% TC2-3 recanalization, and 55% modified Rankin scale less than 2 at 90 days. And this information is from all the old studies from 2012, which were retrospective studies, and the Trevo studies. Trevo is another stent retriever. There was a study in 2012 that compared that to the Mercy retriever, which was the old one, that also showed that the stent retrievers were far better than what we had before. How do they work? Well, we have our angiogram. We have an occlusion, let's say M1, like in this case. We advance our microcatheter distal to the occlusion. Then through that microcatheter, we push that stent out. We push it out. And that stent will start to expand within the clot and cut through the clot until it fully expands. Once it fully expands, we just pull from that pusher wire. We pull everything out. We pull the whole system out, the microcatheter, the stent, and we hope that the clot that we cut through with the stent just comes with everything inside that. This is a 55-year-old male that presented with left-sided hemiparesis 5 hours after the onset. That was 3:30. We started our first angiogram. We can see this is an AP view, carotid terminus, A1, M1, and then there's just a cutoff here of the M1, and there's no vessels here in the MCA. We advance our microcatheter distal to the clot and retrieve this and deploy the stent. These little dots here are the distal markers of the stent. This is the proximal marker of the stent. One of the other advantages of this is once you open that stent, it creates a small path where you can start to have some reperfusion immediately, even before you retrieve the clot. So immediately after we deploy the stent, we cut that ischemia, and we have some reperfusion. We pull the system out, and then hopefully we'll get a piece of clot out. You can see the stent here, a little piece of clot. This is the, in this case we had to have, we did 3 passes. So we advanced the stent, deploy, retrieve everything. We didn't get anything. Went back again, did the same thing, and by the 3rd time, we got the clot out. So that was about an hour that it took us to reperfuse everything. This is the CT of the morning after, with a little basal ganglia stroke. The rest was spared, and the patient did very well. And
So when you're doing it, so you're parking another catheter close and you're just using a microcatheter?
We have a guiding catheter down here at the cervical ICA, so that stays there.
So you can get in and out relatively quick.
Exactly. So that bigger catheter, a 6 French catheter, well actually an 8 French or a 6 French catheter, you can park it at the cervical ICA, just at the neck, and then you just advance your microcatheter inside the head. And then when you pull that system of the microcatheter stent out, you're left with your guiding catheter, and you just go back in again with everything. Very similar patient, 1052, this time on the left side. And then by 20 minutes later, we were able to get that piece of clot out. And that's reperfusion. Patient completely asymptomatic the morning after. So the time window that we use, is it useful? Well, I mean, it just gives us an idea. It's not completely useful. This patient had an onset of symptoms with an NIH score stroke scale of 5. onset at 8:30 a.m. This was done, the first angiogram was done at 7 p.m., so almost 12 hours later. We can see there's something missing here. We do see the M1, but then there's one branch missing that we're not looking at, and that's what we recanalized. We finished recanalization at 7:50, so that was almost 12 hours after the onset of symptoms. And this is the CT the morning after, NIH stroke scale of 0, and that tiny insular stroke was what was left. And that's why all these trials use advanced imaging, because collaterals have to, collaterals are the reason why some of these patients can endure 12 hours of occlusion without having those large strokes. And we have this one, onset at 12 p.m., hyperdense MCA strike, CT scan, 3:14, that's 3 hours later. You already have that large stroke. So that's within 3 hours, not even for TPA, the patient didn't make it, no collaterals. So really the time window is not all there is. So what do? We have a patient with stroke symptoms, and okay. The arrows are black, and they're supposed to be white, but you get a patient with stroke symptoms. You get a CT and a CTA. If there's hemorrhage, yes, well, we stop or we go with our hemorrhagic stroke algorithm, but we don't do any TPA, anything needs to be done. No hemorrhage. The patient is within 0 and 4.5 hours. We give IV TPA, and if there is a major branch occlusion, ICA terminus to M2 or the vertebrovascular system, then the patient has to be taken to the interventional suite. If there is no major branch occlusion, then we don't need to do anything else. That's it. The patient may be having a small perforator stroke, lacunar stroke, very distal M4 stroke that we're not seeing on the CTA. That doesn't mean the patient should not get IV TPA. So major branch occlusion is not within the indications for IV TPA. So the patient should get IV TPA even if there's no major branch occlusion. But if there's not, then we don't need to intervene. And you can see here the aspects 7 to 10. So what's the aspect score? Aspect score is the Alberta Stroke Program Early CT score, aspects. It's a 10-point quantitative topographic CT scan score. CT is always the first line in the diagnostic test for strokes, and is very fast, and is widespread availability, and is very low cost. So these guys here in Alberta devised a scale to help triage patients to see which ones would be suitable for endovascular. So there's a lot of studies that have suggested that early ischemic changes in the non-contra CT before the administration of acute stroke therapies can predict functional outcome and the risk of intracranial hemorrhage. All the previous trials that I showed, they also looked at the aspect score. So what are we going to look at in the non-contra CT scan? Focal parenchymal hypodensity, cortical swelling, sulcal effacement, loss of gray white matter differentiation, and you know sometimes we see that hyper MCA sign. We're going to get our scan from the skull base to the vertex, parallel to the inferior orbitomeatal line, and the aspects is going to be applied to the non-contra CT scan. And all these trials have suggested that an aspect score more than 6, sometimes even 6, 7, 8, 9, 10, is associated with a greater benefit from thrombolysis. So what I propose is that we do here the aspect score. Before we go into doing advanced imaging like CT perfusion, and so the easiest way to try to improve our stroke triage would be to do the aspect score for every patient. It's going to compute 1 point subtracted from 10 for every region that has evidence of early ischemic changes. And these are the 10 regions that we're going to look at. We're going to look at, you don't need to look at 2 cuts. I mean, you look at the whole scan, but if you had 2 cuts, you want 1 through the basal ganglia and 1 through the corona radiata and centrum semiovale. You're going to look at the caudate, insula, internal capsule, lentiform nucleus. You're going to see the anterior MCA cortex, lateral MCA cortex, and posterior MCA cortex in that cut. And then the cut at the centrum semiovale, you're going to see the anterior, lateral, and posterior MCA territories. And that's 10 territories, so that's 10 points. So the patient starts with 10, and then you take 1 for each area that you see some changes. So these are your 10 areas: M1, insula, caudate, lentiform nucleus, internal capsule; M2 here, lateral to the insula; and M3 posterior to the insula. Okay. Just go back because this is. And this is on the CT scan. So this would be so you have your cut. These are several cuts, so you look at everything. But if you, let's say you have only this cut through the basal ganglia, so you're going to have caudate, lentiform nucleus, internal capsule, insula. Then anterior to that, your M1 or anterior frontal, M2 lateral MCA, and M3 posterior MCA. And then you go to the corona radiata, centrum semiovale, and you have 4, 5, 6, anterior, lateral, and posterior. And those are the segments you want to look at. This is an example: patient hyperdense MCA. We have 2 cuts: basal ganglia, centrum semiovale. M1 looks fine, insula looks fine. We can still see gray-white matter differentiation, gray-white matter differentiation. Internal capsule looks the same as the other side. Caudate nucleus, lentiform. M4, M5, M6. You can still see gray-white matter differentiation. So basically, this would be, those are the regions. This would be an aspect score of 10. This patient had an onset of 5 p.m., onset of symptoms. The CT was done at 6:11 p.m., so that's an hour after the onset. Patient still has, I mean, this patient I would take immediately to endovascular treatment. So we have this other one, hyperdense MCA sign. And then we see the scan, basal ganglia, M1, well, that's a little hypodense compared with this. There's loss of gray-white matter differentiation. Sulcal effacement, we can see the insular ribbon is hypodense here. Posterior lentiform, maybe more hypodense here than contralateral side. M3, M2, maybe they're okay, maybe there's still some gray-white matter differentiation. At the centrum semiovale, definitely hypodense here posteriorly, M6, M5, middle. Anteriorly, well, if you want to, you may want to call it, maybe not. So those are the reasons. So we have M1, insula, lentiform, M5, M6. All those are definitely involved. So that's 1, 2, 3, 4, 5, 6. So that's an aspect of 4. So So this patient would not benefit with endovascular treatment at this point. And this is actually the same patient, so onset 5 p.m. For whatever reason, patient just stayed there. At midnight, she got another CT, and at that time she got an aspect score of 4, so even if we go in and intervene and take that clot out, so that's the result at the end. The patient still gets a big stroke with herniation, malignant stroke. So in summary, we think that with all these studies, mechanical thrombectomy with the stent retrievers has finally proven that it's better than IV TPA alone. And we think that it has achieved a Class 1A evidence. We'll see that, but I think it's very obvious that patients benefit a lot from thrombectomy with stent retrievers. So if you're faced with a CTA stroke, with a stroke patient, please order a CTA and a CT at the same time, not the CT and then patient back and then a few hours later the CTA. So both at the same time. We page neurology and neurosurgery at the same time. From my end, I cannot make a decision of whether to intervene if I don't have a CTA. So I'm not going to take the patient in and maybe the patient doesn't have a branch occlusion. So I need to see that the patient has an occlusion. We give the IVTPA if indicated. There's no reason to delay. There's no reason not to give IVTPA. I can immediately take the patient to the neuro suite if you just give an IVTPA. We're going to look for the major branch occlusion and calculate the aspect score. So if we do have a major branch occlusion and we have an aspect score of more than 6, then we go to intervention regardless of the time, and we do not wait for the IVTPA to work, because chances are that it's not going to work if it's a major branch occlusion. Thank you. Any questions?
Hugo, congratulations for all this wonderful presentation. And so this is mainstream, the way you are focusing the patients that are treated here.
Yes, 90% of centers in the U.S. use CT triage for stroke. A lot of them, the ones that already have stroke centers in place, they probably add the CT perfusion to their stroke workup. So they do CT, CTA, and CT perfusion at the same time when the patient goes into the... So that would be, I think that should be our goal to get there, to do CT, CTA, CT perfusion. But I know it's hard, and that's why the aspect score comes into place, and we can maybe start with our CT, CTAs, and then improve on that to a point where we can get CTP. MRI is used maybe in 10% of the centers. Those are the big centers that have an MRI in the ER, and then they can take the patient to the MRI. But most of these studies were based on CT data, and the CT can predict very well whether the patient is going to have good outcome.
The first step, the people that start the whole process usually be ED.
Yes. And they, we've been in talks with them. They're supposed to order the CT, CTA. Sometimes they do, sometimes they don't. Same thing for inpatients that have a stroke in the MICU, in the floor. They should get a CT and a CTA. What's been happening is that they get the CT, and then somebody goes and sees the patient, and then they say, well, let's order a CTA, so the patient then has to go back, and that takes 3-4 hours. And then by the time they call me with the CTA, it's been 6 hours since the patient started. And
you know, maybe we should have like a brain attack thing, you know, a poster that you can, with the sequence of actions, with the algorithm, and posted it in every place. You know, it's not complicated. It's very straightforward.
No, it's not complicated at all. It's just, I don't know where the block is. So, like,
When
but
we call our residents and they say, I've got a patient with a possible stroke, we want a CT, and our residents say, and order a CTA also.
Yeah, that's the
I think we can do that for sure. We definitely do that. We mentioned it to them. I think you were sitting next to me one time when I recommended like a stroke protocol to the ED, and it was kind of a vague history, but they said, no, I just want to knock on CT. Like right now. So I think they know.
But I think, you know what, it's 90% of this is education.
And we can recommend it for sure. If we have a history of stroke, the residents can definitely recommend doing the stroke, because there's a stroke protocol, CT and CTA together.
Yeah, well, you know, the thing is, the people, the clinician need to know.
Yes, sir.
And they always call you if they have stroke.
Yes, sir. Yeah.
So you
And we have to look at it, you know,
Yeah,
immediately.
I know what he's saying, you don't have to run around with the other person. Which, if everybody's educated, everybody understands what's going on, you know, it's just stroke protocol.
For a hemorrhagic stroke, intraparenchymal hemorrhage, is there any detriment to the patient getting like a bolus injection of IV contrast? Like
the patient is still going to have a CTA. If the patient has subarachnoid, it's still going to have a CTA.
What about like basically like intraparenchymal hemorrhage? No problem.
Still going to have a CTA.
Okay.
Hugo, so MRI will not change management, right?
No. We do get an MRI. If patient has a stroke and then we get a CTA that is clean, then we recommend an MRI just to see if it's a lacunar stroke, small stroke, distal stroke. But that can be done later on.
In the CTA, you look for M1, M2, A1, A2.
ICA occlusion. ICA.
That's it.
So the aspects criteria is based on the fact that there has to be a large vessel occlusion. Till what level in the arterial tree is the large vessel considered, like M1, M2, M3? Where do you decide?
M2 and proximal?
M2 and proximal. Okay.
That's large
And
vessel.
the posterior circulation?
Posterior circulation is the vertebral basilar system, like basilar and vertebral artery, that would be a large vessel.
Once there's a hemorrhagic stroke, you're not touching it, is that correct?
No, if there's an hemorrhagic stroke, the patient may go for aneurysm embolization or AVM embolization, but those are not emergent procedures. I mean, they're
You're not going to be endovascular, you're not going to go roll through that clot.
yeah. I mean, and there's no emergent need for something else done at the time. I mean, unless the patient has, you know, midline shift or something like that, that's going to go to surgery. But if it's a subarachnoid or intraparenchymal hemorrhage that is not causing midline shift, the patient will need some other studies, but they can be done the next morning or a few hours later. With stroke, if we delay 1 hour, 2 hours, 3 hours, then the patient's chances of getting better are less and less. Somebody else? And that
How often do you do these procedures here?
probably, I mean, on average, maybe 1 a month. But it's because usually they come in pairs. I usually do 2 in a week, and then 3 months without anything, and then 2 in a week.
Do you know what percentage of ischemic strokes are large vessel occlusions?
No.
Is it a pretty high percentage? Or?
That depends on the NIH stroke scale. When the patients have, if you have a patient that has just like arm weakness, and that's it, the chances are the patient is going to have a small vessel occlusion. If you have arm, leg weakness, and aphasia, then that gives you an NIH stroke scale greater, and that the chances of having a large vessel occlusion are greater. So it depends on the symptoms.
Hugo, are we the only place doing this in town?
Yes.
That's important.
So yeah, I get probably half of the patients that I do, I get from outside hospitals. And I ask for the same thing, because they ask me, can you take these patients with a stroke? And I ask them, does the patient has a CTA? No. Well, I can take the patient, but I cannot assure you that I'm going to do anything, because once it comes here, and maybe it's a lacunar stroke, it's something that I cannot do anything about. So that's why it's important to get that CTA. That aspect score, if you want those images with the M1, M2, M3 IC, you can have them in the ER and then just check those areas and subtract, if that's it.
Wonderful. Poster, make a poster.